Webinar. Good morning, everyone. Welcome to the Compendio RX Long COVID webinar series. Let me just set up everything. Okay, we still have, I'll give people a few more minutes to call in. I think people are logging on. I'll just wait for one more minute. Okay, so we'll go ahead and get started, but thank you everyone for joining us. This is the third webinar series for the CompendiRx Long COVID webinar. So just in general, in this series, you're going to hear about the millions impacted by long COVID worldwide and the ongoing research that's been going on and the efforts made to support practical resources for treatments now. And we will be having a Q&A at the end of the presentation. So if you have any questions, you can go ahead and type in the questions at the Q&A tab, and then we'll try to answer as many as we can after Dr. Akano's presentation. So Dr. Chinonso Akano is a medical professional with over 19 years experience working cross-functionally and across multiple disease states and therapeutic areas, including but not limited to cardiology, addiction disorders, pain management, inflammatory diseases, and virology. As a Gilead employee, he currently works within the U.S. Medical Affairs with COVID-19 and emerging viruses team, scientifically supporting Veklury for the treatment of hospitalized and non-hospitalized patients with COVID-19. He also leads the team's community engagement efforts in educating disadvantaged communities of color through Gilead's cross-functional collaboration with the NMQF Faith Alliance. Dr. Akano earned his doctorate in pharmacy from Temple University, the School of Pharmacy in Philadelphia, and his postdoctorate from Rutgers School of Pharmacy in pharmacoeconomics and health outcomes research. He is a blessed husband and a father of 4 amazing daughters and a son, and currently resides within the Atlantic area in Georgia. In his leisure time, he enjoys the outdoors, biking, hiking, soccer, and is a member of the choir and leads a ministry in his church. Through his foundation, the Akano Foundation, he supports missions in Africa and engages in cultural community development efforts. So we're very excited to have him here. Welcome, Dr. Akano, for presenting. I'll stop sharing. And are you able to share your screen? I think I might be able to make you a host. Let's see if this works.
Let's see. Right, I see it now. Can you see me? Can you see the slides yet?
Yes, we can.
Okay, perfect. Now I need to get my camera up. So let me put my camera on so you can see. There we go. All right. So welcome. Good morning, good afternoon, depending on where you are in the country. My name is Chinonso Akano, as our host has clearly stated. It's a pleasure. It's actually an honor to be with you today. I am a medical scientist with Gilead Sciences, mostly in the emergent viruses, the virology franchise here at Gilead. And today I'll be talking a bit about long COVID. Before I get into long COVID, as we all can remember, the evolution of the COVID-19 pandemic has really taken a toll, and most of us have lost or known someone who have lost someone as a result of COVID-19. If you recall, the first cases of COVID-19 began way back in December of 2019, but it wasn't until March, actually, of 2020 that the World Health Organization declared COVID-19 as a pandemic. And since then, a great deal of research and progress has been made since the beginning of the pandemic, with understanding the variants and the virus, and also with the availability of protective measures such as vaccinations and treatments have followed suit ever since. So my talk today would specifically be on long COVID, and would be really happy to carry everyone along as we move forward. So next slide. So what we see in this slide is just basically what long COVID presents. It has emerged as very persistent and a multi-systemic condition for so many in the US and outside the US. It's characterized by diverse, often severe symptoms that affect all organ systems in the body. Um, how do we define long COVID? It's defined by the World Health Organization as a post-COVID-19 condition which occurs in individuals who have a history of a probable or confirmed SARS-CoV-2 infection. And it typically happens, usually 3 months from the onset of COVID-19 with symptoms that persist or at least last for about 2 months, and in most cases cannot be explained by any alternative diagnosis. And that's how the WHO defines it. Now, some of the common symptoms include fatigue, shortness of breath, cognitive dysfunction, but can also include others as we experience it differently, and those symptoms actually manifest themselves differently as well. Generally, they impact our everyday functioning, as we all know, and these symptoms may be new onset following initial recovery from an acute episode, or it could persist from a previous illness. And they fluctuate over time, and could relapse over time as well. So the term long COVID really accounts for two phases. As you can see at the bottom of the slide, it accounts for the symptomatic phase, which occurs between 4 to 12 weeks. And then it also accounts for post-COVID-19 phase, post-COVID syndrome phase, which is about over 12 weeks in terms of its symptoms, its symptomatic phase. And it's always based on the duration, as you can see with the timeline. So again, the incidence is really 10 to 30% of non-hospitalized cases as at the time when the data was pulled. Based on the study here, you can see it was put in 2023. 50 to 70% of cases were hospitalized cases, and about 10 to 12 those cases were vaccinated cases. And all age groups get affected, and disease severities, which is where you see the highest incidences. It's mostly those who have pre-existing conditions such as cardiovascular, pulmonary issues. But patients aged 35, 36 to 50 years old is where we see the highest, incidences, as well as those who are non-hospitalized but have mild acute COVID as well. So even though COVID was initially recognized as a respiratory illness, right? People couldn't breathe, there were ventilator issues, there was, smell, we couldn't taste, but our pulmonary, respiratory system was really compromised. But it doesn't shock us to look at this slide and see that it can damage multiple organ systems. Um, and I won't go through all of it, but we'll talk about some of these, all of these in a bit more detail. But The most reported symptoms of long COVID are mostly exhaustion, cognitive dysfunction, chest pressure, or tightness. Shortness of breath is also mostly seen there too. Most folks present with headaches, and then the muscle aches, the myalgias that really come across as a result, and some heart palpitations too. So we'll discuss some of the most debilitating symptoms in a bit. But however, as you can see on this slide, we have respiratory, neurological, and cognitive symptoms are a major feature of long COVID and can include memory loss, actually, and impairment, paresthesia, dizziness and balance issues, sensitivity to light or noise. Loss of course, we know this because most people presented loss of smell or taste, and then ringing of the ear, we also happen. So all these, as you can see here, were also affected. Cardio, the most common cardiopulmonary symptoms in people living with long COVID include chest pain, dyspnea, palpitations, and syncope. So long COVID sufferers, it's good to point out that they may also experience, myopericarditis, or right ventricular dysfunction as a result also that whole symptoms of suffering from long COVID. Now we'll talk about the gastrointestinal tract here, and we'll talk a bit about this. It includes pain, GI pain, nausea, loss of appetite. Even weight loss has been seen in folks who are going through this long COVID effects. So irritable bowel syndrome has also been seen. So the COVID-19 infection has been associated with new onset diabetes and altered metabolism as well. But it's good to point out when it comes to our kidneys, about 1/3 of patients develop kidney injury after acute COVID infections. Now, looking at our skin on the dermatological side, after acute infection of COVID, some patients did report rash and hair loss also. Reproductive system, there have been reports of impairment in reproductive functioning, including delayed menstrual cycles, impaired sperm volume, morphology, or motility as well. And most of these have been documented in some of the papers that are currently still being studied and still coming out. The one I reference here is also the one by Dr. Davis and colleagues, and that I'm referencing here in this particular slide. So next slide, we are going to talk about long COVID symptom clusters, how it emerges in some individuals after being diagnosed as having an acute SARS-CoV-2 infection. Now, when we look at this study, I won't go into much details, but I can have this available for you if you want to dig a bit deeper. But based on this analysis, it's a meta-regression analysis where we looked at 54 studies and 2 medical record databases over from different countries in 2020 and 2021. We did see that to estimate the proportion of males and females living with COVID-19, we wanted to assess the severity of their symptoms. That was the whole background and the basis objective of this particular study. Now, looking at this, we can see that, proportions of long COVID symptom clusters among individuals 3 months after infection really continues to persist. It's ongoing, and most folks have ongoing respiratory problems. 60% of those, which is where you see most of those based on this particular data. Now, persistent fatigue and bodily pain, like I mentioned earlier, mood swings accounts for about 51%, and then cognitive problems accounts for about 36% in this particular case. Now, long COVID symptoms remained at 12 months in 15% of the cases that this particular data shows us. So I guess the take-home message here is that these symptoms and these clusters do continue to emerge. Respiratory, fatigue and myalgias, as well as cognitive problems, these clusters continue to emerge in some individuals once they've suffered, acute SARS-CoV-2 infection. And then in this slide, I wanted to highlight what those symptom clusters are and how it varies across multiple waves and variants. So there are different variants from when we started the COVID pandemic. As you all can imagine, variants have continued to emerge over time. When we started, it was the Alpha variant, the Delta, Omicron, and now we're into a different flirt variant now, which is more not as lethal as we had with the Delta, so also parts of Omicron, but it's actually more contagious. So what we see before us now is basically depending on which wave you're in, and the time period is also listed here, and the predominant variants are also on the right-hand side here. Regardless of the wave time period and the variants, we continue to see a greater proportion of palpitations were reported in those who suffered from COVID-19 from waves 1 and waves 2 than what you see from wave 3 and wave 4. Um, so palpitations account for what, like wave 1 and wave 2, you have 35% and 28% of folks who suffered from palpitations and chest pain as well within wave 1 and wave 2. But when you compare that to wave 3 and wave 4, you see it's about 12% each in wave 3 and wave 4. Even though it's significantly greater in wave 1 and wave 2 with a p-value of less than 0.01, those are still taken seriously by those patients who suffer them in wave 3 and wave 4. So these symptoms vary, right, from from the data we pulled and the time period and which variant was predominant at the time we cut it off. So you can see, poor concentration, GI symptoms, fatigue, joint pain, headaches, they do vary as, depending on the wave. But the most significant ones that you see was the palpitations and the chest pains. Those were more higher earlier on in the 2020 with the the predominant variants at the time between August 1, 2020 and end of the year of 2020 compared to those that happened afterwards. So just something for us to, to really be aware of as well. Now, in this slide, some therapies are now being used for children, some are not. But children with long COVID experience very, very similar symptoms as adults. But they also present with other features as well. For example, in adolescents, as in adults with long COVID, females appear to be disproportionately affected, believe it or not. In two different studies, on the left in blue is a long COVID in children and adolescents in a US-based study. On your right-hand side, it's a Danish-based study, also in adolescents. But these are different studies. On the left is a retrospective cohort, and the Danish study was a cross-sectional study looking at adolescents as well. Now, the background and the objective of this study was to basically identify diagnosed symptoms, what the health conditions were, and what medication were associated with this acute sequelae of COVID in children. And the methods I just typically mentioned here. But, children and adolescents in this study showed features that have been well described in adult populations. In this pediatric population, features such as abnormal liver enzymes, hair loss, skin rashes, diarrhea occurred more commonly actually in children in the 1 to 6 months after, being tested positive for SARS-CoV-2. Now, this is in comparison with those who tested negative, is what I'm trying to allude here, as you can see also. So these other studies that looked at the severity of COVID-19 infection also were associated with long COVID symptoms in children too. On the right-hand side, you have those most frequent ones: headache, fatigue, loss of appetite, breathing, and this trouble remembering or concentrating in the classroom. We saw that in kids too. Mean ages in the Danish study was about 17.7 years, mostly female. And also in the US-based study, about, the mean age, when you look at the standard deviation, was 8.1 years, but you can see it's about 52.8% male. Now, knowing this information that children can also experience the similar, symptoms as adults, it's also good to understand what those risk factors that are for long COVID. People experiencing long COVID were consistently people who are of working age, more likely to be female than to be, and also likely to be hospitalized or have very symptomatic disease. Now, in surveys that were conducted of patients with long COVID, some of the participants reported poor pre-pandemic general and mental health. So they were really having other issues that were going on prior to the pandemic hitting. Some of them also tended to be of lower income And especially in the United States, we're more likely to be of mixed race or Hispanic. And with that said, on the left are some of the risk factors, and on the right are some, the socioeconomic factors as well that I just alluded to, for those risk factors for long COVID. So on the right-hand side, I know we talked a little bit of the risk factors, asthma, smoking, general health, but on the right-hand side, you're at risk. So the socioeconomic risk factors include lower income if you're Hispanic or Black, but less educational attainment puts you at a risk also. Inability to rest adequately in early weeks after the COVID-19 infection put you at risk. And of course, if you're immunocompromised too, but also if you're disabled as well, puts you at a higher risk in a socioeconomic standpoint. So these are the things that have not just reported by the National Center of Health, the CDC, but it's also constantly being mentioned in some of the publications that are coming out too. So there's some consistency to them than just a one-off study that was looked at. Now, in people that did receive COVID-19 vaccines and had breakthrough COVID infections, we did see an increased risk of long COVID depending on how severe that their disease were. So what you see before you on this slide is basically an electronic health record database from the VA, basically between January to October of 21. And it did compare, the objective was to determine if individuals who had breakthrough infections after being vaccinated, who had COVID-19 vaccination, if they did experience long COVID or not. And as a result of that, patients who had that breakthrough infection had a lower risk of long COVID if they were vaccinated versus those who were not vaccinated. So it was better to be vaccinated. And those who were vaccinated vaccination was most effective in reducing those blood clotting disorders that folks would present, and also lung disorders, as you can imagine, as the respiratory tract took a hit. So you have 56% of that reduction, reducing the risk of blood clotting, and 49% reducing the risk of lung disorders. Now, what's also another important factor here is the range of long COVID symptoms. Now, which is broad, right? These symptoms were observed in patients with breakthrough infections. Really, those symptoms who were observed in those patients with breakthrough infections did not appear to differ from unvaccinated patients. So there was really not delineation, if you will, whether you're vaccinated or not, because those range of symptoms really appeared or break as a result of people who had COVID-19 or had a breakthrough infection. So bottom line is vaccines absolutely are important and a very important component, especially if we're preventing, in some cases, death, mortality, also even preventing the risk of progressing, right, as a result of being diagnosed with COVID or leading to long COVID. Now we're going to delve into the pathophysiology for a bit, and I'm just going to highlight some of the multiple mechanisms that are involved in long COVID, and then we'll talk about them individually in a nutshell without going too much. I wouldn't have enough time to delve into them, but we'll start with, and I talked about this, alluded to this earlier in the beginning of my presentation. These are the multiple mechanisms involved, starting with immune dysregulation, the microbiome, autoimmunity and immune priming, blood clotting and endothelial abnormalities, and then we have dysfunctional neurological signaling. Now, there are several overlapping hypotheses of long COVID pathogenesis, which includes some of the things, all these that I just mentioned. But now, the most striking, and I'll go through this one by one in a nutshell. My ask is to pay attention because some of you may have experienced some of this, or know someone who have experienced some of this, and continue to experience some of this. It's important to identify that it could potentially be a long COVID issue that continues to linger over time because it's still currently being studied and elucidated a little bit further. Now we'll start with immune dysregulation. Now, the pathophase of long COVID is not well understood. I'll state that clearly. However, there are several overlapping hypotheses, which includes this particular one. Over here, you can see that there are persisting reservoirs of SARS-CoV-2 in tissues that could drive those chronic conditions after being infected, after acute infection. Now, these viruses in turn may dysregulate the host response during the acute COVID-19 infection, giving way, allowing the previous harbored pathogens to reactivate. It reactivates them, and then these reactivated pathogens then replicate and infect new body sites, driving new chronic symptoms that some folks tend to present as a form of long COVID over time, sometimes weeks after the infection has occurred. That's the way it happens, and the immune system gets dysregulated. In terms of our autoimmunity and immune priming, the microbiota, another possible mechanism here is our gut hormone, our gut microbiome. Um, and most people have heard about this, how everything is really centers around the gut for the most part, but depletion of our immunomodulatory gut microorganisms in patients who have severe COVID-19 has been associated with increased plasma concentrations of several cytokines, chemokines, even inflammatory markers as well. And now this suggests that our gut microbiota could play a role in modulating host immune responses. Now, some gut microorganisms were enriched in patients who experienced symptoms up to 80 days after recovery. So think about 80 days, months and months after you've been recovered, you still have experienced symptoms, within your gut. And that's why this is also affected as well. And it affects our immune system, generally speaking, because dysbiotic composition of our gut microbiota, if it persists over time, right, even after recovery from SARS-CoV-2 infection, it could still play a role in those symptoms that some patients experience as well. So I find that quite fascinating too. Next would be autoimmunity and immune priming. Now, another proposed mechanism here of long COVID is the damaging and self-sustaining autoimmune response against our self-tissue antigens. During this acute SARS-CoV-2 infection, right, the innate and adaptive immune responses get activated automatically. It's a given. But when that happens, antibodies produced by our immune system to fight COVID may also mark the individual's own cells as foreign and in turn will attack it. So the B cells could, present both COVID and self-antigens. Auto-reactive T cells could increase the production of these, cytokines and damage tissue via cytotoxicity, if you will. And the body is then primed, right, to respond to COVID, and self-antigens and autoimmunity is turned on. And the attack persists even after the virus is gone. Hence the long COVID symptoms folks would experience as a result as well. So, you can tend to see the relationship here, how things are kind of related, and our body systems and, kind of are related. And these symptoms are absolutely different for everybody, but there's some consistency in some folks. Now I'm going to talk a bit about the clotting and endothelial abnormalities. So long COVID symptoms could be due to, again, organ or tissue injury, especially in severe cases. If you have severe cases of an organ injury, COVID-19 could exacerbate it. That infection could be exacerbated. Now, more than 1 out of 3 of patients who recover from an acute infection tend to develop lung abnormalities, so pulmonary issues is characterized by, when our lungs get scarred. And that scarring of the lungs can present as stable in response to an injury, or the infection, SARS-CoV-2, can make it more progressive, right? And make it more rapid and exacerbate that particular experience. Both stable and progressive lung disease can result in, the deposit of extracellular matrix molecules such as fibronectin, collagen, laminin, in our, lung tissue, in the parenchymal lung tissues. And this leads to, of course, endothelial injury, epithelial injury. Our alveolar walls get thickened, which can hinder, exchange of gases in the lungs and increase the symptoms of fatigue, dyspnea, exercise intolerance, So all that makes it even worse to breathe. And as a result, the blood vessels can become damaged by all these endothelial cell activations and, coagulopathy. And, it just makes it worse. You have microbleeds, and then some patients really experience stroke as a result. So it's just a continuous exacerbation, which makes it more difficult for those patients over time, of course. Last but not the least, we'll talk about dysfunctional and neurological signaling. So many of the symptoms of long COVID resemble like muscle pain or myalgic encephalomyelitis or chronic fatigue syndrome. Now, and these can be considered post-infection syndromes as well. So SARS-CoV-2 may directly, as you can see, may directly invade the brainstem during acute infection. Now, if the brainstem is infected, it gets inflamed. And once it's inflamed, an infection would persist that may drive long COVID symptoms to be experienced over time, without going into too much detail. But that insult could really drive some pro-inflammatory, production and really, exacerbate the long COVID symptoms that most patients would really experience. I'm going to segue now into the burden of this disease, what it feels like, and, what people are experiencing as a result of long COVID. Now, I wouldn't be able to play this video for you, but I will talk a little bit about it. These are actual quotes from patients, have that are suffering or have suffered from long COVID and the challenges in managing their daily life. I'll just read about two of them. One patient says, I was unable to manage complex information as I was forgetting words. I had problems doing simple tasks and basic logic problems that I would normally do these easily. Um, Another patient says, and you start having employers kind of doubt you as a result because you don't have this diagnosis, and your family members kind of wonder, did you just burn yourself out? Or like, are you just stressed? It's really difficult to be the only one that really knows that something is wrong, because it's hard to explain, and you're only going through the symptoms alone, right? Um, Now there is an ICD-10 code, I believe, for COVID, long COVID, but still the research is still ongoing. So, living with long COVID is very difficult because you listen to each patient and as they discuss their experiences and share their real life experiences and how debilitating these conditions can actually be. Now, in a nutshell, this is a UK-based study, a survey rather, that really confirmed, I suspect, who confirmed for us that, people living with long COVID experience challenges in daily living, including the, inability to attend school, employment, difficulties, and also having mental health challenges as well. If you recall, mental health was a big issue during this time because of, the neurological, insult that gets affected as a result of the virus. But this is basically a survey that really explored initial and ongoing symptoms of long COVID and really aims to describe the impact it's having on daily life. Again, it's a lot of people, over 2,000 adults, that had a duration about over 7 months, about 46 years old, mostly females and mostly white folks. And more than about 90% of them reported good, very good, or excellent health prior to COVID-19. So upon suffering from it, of course, some of the most symptoms included mostly exhaustion, just being totally exhausted as a result, cognitive dysfunction we just talked about, chest pressure or tightness. And again, these were absolutely heterogeneous across the board, headaches, muscle aches, palpitations, but 58% described fluctuating, relapsing symptoms, as well as 18% on physical activity, stress, difficulty sleeping. Just a few patients reported, returning to baseline health at the time of when this survey was completed. But 98% reported that they had not recovered. 98%. And that functional impact it continues to have, it's really debilitating, and it's hard for me to explain. I haven't, but I'm hearing patients going through it, you begin to wonder why is it continues to linger over time. And I won't quote what's down there, but you can see 99% suffered from symptoms of depression, pain, anxiety. 64 were unable to perform just the regular daily activities, just, being able to walk out of the door, sweep, the front porch, just can't do it anymore. 32% were unable to live alone, and 19% were unable to work. And that was the biggest impact in the economy, was people not returning back to work as a result of long COVID. Now, this also builds on that. This is a survey from over 3,762 adults with confirmed or suspected COVID-19, and this is across different countries, with illness lasting over 28 days on the left. On the right is also another survey, mostly in the UK, of folks who also had COVID and self-reported long COVID. Now, the message here is that these surveys of people living with long COVID reveals to us the significant impact it has on the economy, reducing the labor force and resulting in loss of income. 45% of folks, of workers, reduced their hours as a result. 22% were out of work at the time of this survey due to long COVID. On the right, you see 38% reported loss of income in the UK. So it begs the question, or it just begs the question, what are we doing from an economic standpoint to really address patients who are going through this, because it seems like it's continuing to linger. Now, company and government level policies did support workers suffering from long COVID, but I think more is still needed as we begin to understand the impact this is having on the workforce and the economy as a whole. So when it comes to racial and ethnic minority groups, we know that collectively, right, racial and ethnic minority groups experience a higher burden overall of long COVID compared to their white counterparts. So when you compare white individuals, Black and Hispanic individuals, you see that Hispanic and Black individuals have a higher rate of COVID-19 hospitalization and death compared to white individuals. But less is known about the racial ethnic differences in long COVID. We don't actually have all that yet, but we do. That is currently being studied and being elucidated. Some folks in Louisiana, in Tennessee, and the academic and research institutes are doing a lot of work there too. But it's important to see those numbers translate here. On the right side, you see that long COVID rates are higher in people with lower levels of education. Remember, I hinted to this when I talked about risk factors earlier. You can see the percentage. If you don't have a 4-year college degree, it's only 15 to 17% of patients who are experiencing long COVID by your educational level. So it's higher if you don't have a college degree, but a little lower if you have a bachelor's degree or lower. Now, this relationship is, again, it's really well established. So it's likely that the rates of long COVID are higher among people with lower incomes, as you can imagine, because of access issues, being knowledgeable about the disease, et cetera, et cetera. So these are things that we've really been able to capture some data on, and I'm presenting to you today about, just to be aware. And again, the CDC has also reported this in a huge number of patients. You can see a huge N of over 74,000 folks as of February 13, 2023. So that's a huge number as of last year. Who knows what those numbers will be this year? Now, again, looking at a retrospective study of over 62,000 adults who received a positive COVID-19 diagnosis in New York City between March and October of 2020 to October 21. When you compare those to who were negative for COVID, and then looked at symptoms between 31 and 180 days post-COVID diagnosis, we did see that out of 13,106 hospitalized adults who had long COVID, Black and Hispanic adults were disproportionately represented. So let's look at these 3 buckets now. On the left, you have Black adults. They were 2 times more likely to be diagnosed with diabetes as a result, and more likely to have headaches, chest pain, and joint pain when you compare to their white counterparts. The Hispanic adults were also more likely than white adults to have headaches, shortness of breath, joint pain, and chest pain. And when it comes to our white adults, they're more likely than Black and Hispanic adults to have sleep disorders, so difficulty sleeping, cognitive problems, and fatigue. And we're looking at a huge number here. We're not talking about hundreds of patients. We're talking about tens, 13 plus thousand folks. So there is a trend. Unsurprisingly, though, to me, in addition to these varying rates of ethnic and racial disparities in long COVID, I think it continues to merge, right, as we've seen with some acute infections over time. So it's something we're still keeping an eye on. Again, this is an electronic health record data in New York City specifically. So it hasn't been translated to what other cities are also seeing. So it's a really huge database, and it's important to see how it affects racial and ethnic minority groups. So now this is also from the previous data that I just showed. Over here, we're also seeing that among those who were hospitalized from COVID-19, several racial and ethnic differences in incident conditions were observed. So, right, when you look at those conditions that were really affected more Black and white folks, you can see the endocrine conditions, right? 19% in Black, 17% in the white population, and you can see the p-value. General signs and symptoms more in the Black population. Same thing with the circulatory system disorder, same with anemia, right? We continue to see that, the differences there. What we see that is more prevalent, or, the incidence is higher rather in the white population is the nervous system conditions. Like I alluded to that also in the previous slide, where you see that 16% in the white population and 14% in the Hispanic population. So, the disparities are there. The similar differences were still observed in those who were non-hospitalized with COVID-19, but the absolute rates of the incident symptoms and conditions were lower. I say all this to basically point out to the comment at the bottom there that there are different mechanisms that explain racial disparities. And although we don't have head-to-head to compare, it's still a little bit unclear, to be quite frank. But we have seen trends and how, they may relate to higher rates of viral exposure, poor access, right, to quality medical care can really be an issue that is leading to some of these disparities. But more importantly is the impact it's having in our workplace. For me personally, I think it's something that we need to look at because, there's a higher risk of long COVID symptoms in racial and ethnic minority groups, but the impact it's having in their workplace could be more, damaging, if you will, and could lead to loss of work, termination. Depression could also be an issue as well in these communities. So long COVID, again, has also reduced the labor force and wages. So the financial costs associated with labor shortages due to long COVID are estimated to be quite substantial. The Brookings Institute estimated the number of people who lost work from the workforce due to long COVID in some reports late last year. But you can see on this slide right here, the number of Americans out of labor force due to long COVID. On the right are working age Americans who have long COVID today, as of when this was pulled, 16.3 million. Compared to those who are working age who were likely, who were likely in the labor force pre-illness, you have 12.2 million. And then look at full-time equivalent workers out of the workforce, 4.1 million. So that's a lot of folks. I don't know about you, but it's a lot of people. So when you look at those numbers, which jobs are they leaving? They can't use the mental disorders that enable them to function. It's no longer there, and it's not because they don't want to go back to work. It's the symptoms and the effects of COVID-19 over time that is really debilitating. That led to that. Now, on the annual cost, when you look at the lost wages due to COVID. From different analysis from the feds, the trade union, Congress data, and then the Lancet, you can see the amount of lost wages, 105 billion. TUC data, 168 billion. The Lancet reported 235 billion. Now, this is amount of money that are lost wages annually, and it's a lot of money. It's costing the economy so much, and I think it's time we start paying more attention to it. However, the studies that are being sponsored also by the NIH and some academic institutions, and also companies are sponsoring studies to see what these long COVID effects would be like down the road. We're still learning, and those research is still ongoing. But it does have a huge effect in reducing the labor force and an impact on wages as well. Now, home stretch here. So this is the public health and economic burden long COVID presents. It's quite significant because it's reasonable to assume that treatments for long COVID will incur increased spending, right, on medical care. If there is a treatment, it would absolutely be more. But one US estimate, did project that the cost of medical care for long COVID could be over $500 billion. Now, this was a projection and looking at the impact of long COVID in the US. But, you can see from this pie chart here, the reduction in our quality of life would cost way more, 2.2 trillion, compared to, medical spending and reduced earnings over time. So the direct medical costs of long COVID were much greater than non-long COVID patients, as you would presume, right? But this study looked at over 180,000 patients from March of 2020 to March of 2021. So basically about a year, and is a retrospective. So we went back into the database to take a look. And during the acute phase of COVID-19 infection, those patients who had long COVID had a lower use of these services than when you compare it to long COVID patients. But the mean cost per user was 52% higher. What does that mean? So if you have long COVID, you tend to use some of these, use more resources, right? More doctor visits, more medications, your quality of life goes down. It costs more to treat than patients who don't have long COVID. But it also costs those who have long COVID a lot more than those who don't have. So it costs the system more, and it also costs the patient who's also experiencing it, costs them more as well, 52% higher. So all in all, it's something we really have to address. It's a public health concern, a significant one for that matter, especially when it comes to economy. Now, I'm going to briefly talk about how do we now begin to, going to a doctor's visit is not going to cut it to figure out if you have long COVID or not. It's complex, and it involves a very huge multidisciplinary effort. So it needs a multidisciplinary effort to be able to make sure that, this has been addressed. So the multisystemic nature of long COVID, it just takes all of us, whether you're, a hematologist, a neuropsychiatrist, or, primary care, kidney, renal physician, it doesn't matter, cardiologist, patients who have to seek services from multiple specialists, that like if you have blood pressure, or you have a stent put in, and you have to go see your kidney doctor if you have, renal failure or whatever, they need to talk to each other. Those services are needed for long COVID management. Because long COVID manifests in multiple organ systems, and that evolves over time. So to assess and treat various symptoms across organ systems, whether it's testing or treatment, it requires the patient to really cycle through multiple specialists and clinics. And it leads to a huge use of healthcare resources as well. So it's important that we begin to coordinate better and collaborate better across multiple specialists. I think is really essential to achieve not just effective quality of life, but efficient patient care. It's the right thing to do. It's easier said than done, but I think we're hopefully a step in the right direction here by addressing, highlighting that too. And it takes multiple, the pathways can be complex, right? This schematic that you see before you really shows the the care pathway model based on systemic review of other international care models for long COVID. So this is coming from different alliances, some in the US, some other systems, but it's basically talking about primary care is typically the entry point. That's where it starts. The entry point is primary care, and then central source to, of referral to other specialists. A wide diversity of healthcare professionals and medical specialties are involved in this long COVID pathway. Patients are often referred to, specialty care or rehabilitation, depending on their symptoms and their needs. But most importantly, the patients ultimately need support, whether it's medication management, self-management, comorbidities management, long-term follow-up, mental health is important. Overall, I mean, managing long COVID requires an extensive long-term healthcare resource use. So it's challenging. It's not easy, but it's challenging to implement this pathway. It may include people having to wait longer, difficulty training physicians, educating them about, how interrelated this, we need to be more concerned and involved in the patients more. Barriers to access, absence of, I guess, multidisciplinary rehabilitation, if you will, and also funding, long-term funding sustainability. If we identify that this is an issue, long COVID is, then let's fund it and put resources towards it to better support this integrated care pathway, because it's really needed to effectively manage and support patients who are suffering from long COVID. At this point, I want to thank you for listening. I appreciate your time. And in conclusion, I'll just tidy up with some nuts and bolts here, which we've kind of talked about earlier. And I won't read everything, but we know long COVID symptoms not only impact our physical health and well-being, it also interferes with our daily functioning, our ability to work, and our overall quality of life. We talked about how multiple mechanisms are thought to be involved in the pathogenesis of long COVID, which includes our gut, our immune system, our endothelial abnormalities, in our neuroinflammation and injury. It's all connected, so we need to be aware of those. And how significant long COVID is. It's a significant public health and economic burden. The last thing we talked about. But also it's important to understand that, women, people with poor health are the economically disadvantaged here and are at an increased risk as well. With that said, we also talked about how more research is needed, right? And that's still ongoing to provide a better understanding of the pathophys and diagnostic treatment options for long COVID. Again, it takes a village, to really make this work. It is a thing. We need more funding, more policies are needed to support the necessary research and establish necessary care to ultimately help patients who are suffering from this debilitating long COVID or post-acute sequelae of COVID-19. So with that, I say thank you very much, and I'll entertain questions if there are any.
Thank you so much for your presentation. Let me up my video. I don't think I'm able to show my video, but we'll open up to Q&As. If you're comfortable, you can go ahead and speak, or you can type it in the Q&A section. I do have a comment from somebody who says, the economic impact data is striking. It's encouraging that Senator Bernie Sanders has now proposed the Long COVID Moonshot Act to recognize long COVID as a public health emergency, and advocates for significant investments in research, education, treatment, and expansion of care. So there are some politicians who are recognizing that this is a big issue, and that they're looking into some support for this.
That's good.
Another question is, what is a time frame that we can expect for development of directed long COVID medications? Is it maybe 1 year, 5 years more?
That's a good question. It's difficult to say. There's some that are ongoing, but the difficulty there is because there are multiple pathways, right? Multiple organ systems involved. It's difficult to have one medication really be able to address all of that. Um, they have been proposing a few things, but I'm not at liberty to say that, but it's ongoing. The research is ongoing. There have been some funding allocated to it to really continue that research, including the government. But a timeline would be, my hope is we need one today or tomorrow, but the science is still evolving, right? And it takes time to get it right. So I'll say we need to be patient as we develop something that is better. It's not a treatment like we developed, not rushed, but we developed for COVID-19. But those treatments are very good today. For long COVID, it's different because as we begin to understand it better, it takes a little bit while, a long time because there's multiple, um, you know, areas involved. So I can't really say exactly how long it would take, but it's coming along.
And just like a follow-up, where can we go to find long COVID treatment trials? Where would you recommend that?
I actually recommend going to clinicaltrials.gov.
Mhm.
To really, that's where the best place to look at it. That gives you, companies who are putting resources towards that, where those studies are going, institutions, boils down to actually the locations as well in some cases. But I would say that, Gilead Sciences, we've looked into that. We've seen some benefit with some treatments for patients who have been on long COVID. Now, the research is too early. We don't know if it's tailored to just because one organ system or not. It could be better maybe for, I don't know, relieve, the pain or help you get back to work, but still having another area that is still lagging. So it's not a silver bullet. It's not one thing that cures all. But I think um, long COVID to find information for that, you either look at, clinicaltrials.gov and it boils down to where those companies are. Then you can go to those company websites to really dig more and find out what they're actually doing. But to that question, I'll also suggest um, that it's important for everybody to be involved if you're interested in participating in long COVID research. Um, because we need these trials to be representative of everyone who's suffering from long COVID. We're not talking about just white folks, black folks, Hispanic folks. I mean everybody. So this, recruitment or involvement of an all of us approach to really participate in clinical trials is really becoming very important. And the FDA has also mandated and put a number for most research companies to really make sure that their studies are representative of the diseases that are being studied in population that are suffering the most from those diseases. So, or just America in general. So we need to participate to, really encourage diversity in our clinical trials as much as we possibly can.
Right. And also, I do want to remind everyone that you can also go to Comprendi um, .rx to find some more information on promising treatments that as a part of our resources. So we do have 1 minute left, but there is one last question if we can make this brief. But do you think it should be the primary care or specialist's responsibility for the care coordination of the patient and ensuring that this plan of care is followed?
Great question. I wouldn't put it on the primary care's responsibility, so to speak, but I think the patient needs to be more proactive in making sure that the primary care is aware of how they feel. The cardiologist is aware of it. So I think the patient needs to take some ownership. But if it's a system that you have all your care being coordinated, then it's in your record, right? But I think your primary care is the entry point because that's the first place you kind of let them know and just own it and then make sure that they're communicating or sending your medical records to your specialist to make sure that there's that care coordination taking place. But I think we have to be more proactive, especially when it comes to this, because I'll tell you, folks are really going through a lot with long COVID and not knowing it's attributed to the previous infections of COVID-19.
Okay. Okay, thank you so much. I think
Thank
that's
you.
all we have for now. We will make this webinar recording available if you want to review it or if you came in late and weren't able to catch up in the introduction in the beginning. But thank you everyone for calling in and participating. This was very informative. And thank you so much for taking your time to listen in on this really important topic.
Thank you, everyone. Have a good rest of your day.
Thank you. Dr. Akano, can you perhaps make me a host? I think there's some kind of issue.
Yes.
I'll end this session for us. Okay,
Go ahead.
thank you so much. All
You're
right,
welcome.
I'll pause this recording and send it to everyone. Thank you so much.
Thank you. Have a good one.
Bye.
Bye-bye.